So let's start with number one. And number one will shock everyone, I think, because the claim I make here is that the true cause, and we call the true cause the causa vera, of atherosclerosis or coronary heart disease is unknown. So how can anyone make that suggestion? Well, the answer comes to me after reading these two articles by Stephens and some of his other work. And he questions, are you dealing with the cause, i.e. the causa vera, or are you dealing with just a reason for the disease? And he says the problem is the epidemiologists have misled us because they've confused cause and reasons. And until you dissect the two and take them away from each other, you're not going to get it right. So, epidemiologists confuse cause with the reasons why a clinical disease has developed and ignore subclinical disease, but cause and reason are not synonymous. For cause to have real meaning in science, it must be the sole requisite without which the disease cannot occur. That's critical. Others too have stressed the need for specificity, including Claude Bernard, the great famous French biologist, who argued that it was important in medicine to differentiate between cause and associated or predisposing factors, because anything else would be denial of science in medicine. And he defines the cause must be both necessary and sufficient for the disease to occur. And that's crucial. But the real point is that if you remove the cause, the disease disappears. So if you think you are treating the cause and the disease doesn't disappear, then you're not treating the cause. You're treating one of the reasons. And that's where we've got it so wrong, because the epidemiologists have told us that there are multiple factors causing coronary artery disease, coronary atherosclerosis, because that's how they look at the problem. But the reality is, until you can reverse the disease completely, you don't understand the cause. So that's exactly as Claude Bernard said. Indeed, proof that a given condition always precedes or accompanies a phenomenon, and that's epidemiology, associational studies, the conditions and the phenomenon, that doesn't warrant concluding with certainty that a given condition is the immediate cause of that phenomenon. It must still be established that when this causal condition is removed, the phenomenon will no longer appear. And that's critical. So if we've got a disease like coronary artery disease and we think we know the cause, once we initiate and act against the cause, the disease must disappear. If it doesn't, we don't know the cause. For proof of causation, elimination of the supposedly causative factor must be followed by elimination of the condition being studied. So key is differentiation between causative and non-causative factors is essential. And this is a key point. Reduction in incidence rather than elimination of the disease precludes a causal relationship. So if you think you're treating the cause, but all that happens is the incidence of the disease reduces, but does not disappear, you haven't found the cause. Critical, you haven't found the cause. So elimination of the cause eradicates the disease, and that's the definition. You have to eliminate the cause to eradicate the disease. So cause must be used as the sole prerequisite without which the disease does not occur. So saying that a particular condition contributes, then it's not a cause, it's a reason. Risk factors are not causes unless proven by other means, i.e. risk factors are reasons, they aren't causes. And so much of what we teach as factors that are associated with coronary heart disease, they are reasons, they're not causes. Clinical coronary heart disease is an inappropriate measure of the severity of atherosclerosis. That's pretty obvious, because you can have severe coronary atherosclerosis without the clinical manifestations, because there's another component, and that's the plaque rupture and thrombosis, which then makes the atherosclerosis clinically apparent. So he concludes misuse of cause, risk factors, and coronary heart disease have led to the multifactorial concept of the etiology of atherosclerosis. And that's led to all sorts of problems. So I had the privilege of debating Professor Jacques Rousseau at the University of Cape Town Faculty of Health Sciences Centenary Debate in December 2012. And this was when I was just starting to get into trouble, and Professor Rousseau was going to make sure that I stopped talking about heart disease and made sure that I believe cholesterol is the major risk factor. And so we had an interesting debate, and he wrote up his side of the argument and I wrote up mine. But this is what he said in his argument. LDL cholesterol is more than a risk marker. It is also a causal risk factor, as demonstrated by genetic studies and clinical trials. Well, you can't have a causal risk factor. That's anomalous. It's either a risk factor or it's causal, but you can't have both. And clearly he didn't understand the distinction, and perhaps I didn't at the time, because I should have tackled him on it at the time. So, and that's point one. Point two is that no study has shown reversal, complete elimination of the disease. It doesn't matter whether it's genetic studies or clinical trials. The clinical trials, as we'll discuss, has shown some reduction in incidence, but not removal of the disease. So therefore, cholesterol cannot be the cause, as I will show you in some detail. Tabas is a very fine cardiologist with interest in the changes that occur in coronary artery disease, and she gave this memorial lecture, and listen to what she says. So this is a person who deals every day with this condition, and you'd imagine that he or she was very au fait with what's happening in the disease. So how can the overall lowering of plasma LDL over the past 3 decades, that is after the introduction of statins, be reconciled with the fact that atherosclerotic vascular disease remains the leading cause of death? Then Dr. Tabas says, despite the enormous life-saving success of statins, which is not true, as we'll show, issues related to potency, real or perceived drug safety and side effects, patient compliance, and patient and provider education have limited our ability to lower LDL to the types of level that would prevent the disease. So we need to do more intense lipoprotein lowering is needed. So in other words, the hypothesis can't be wrong. The fact that it doesn't work means that the patients are not complying and we're not getting the cholesterol low enough. Actually, no, Professor Tabas, the patient's non-compliance is not the problem. The problem is that lowering the blood cholesterol concentration does not prevent coronary heart disease. So elevated blood cholesterol concentrations are not the cause of coronary heart disease. Your hypothesis is wrong. And you would think that after 30 or 40 years trying to prove that cholesterol causes coronary atherosclerosis, and without achieving anything, that these cardiologists would like to change their hypothesis, but that's pretty impossible, it seems. Peter Libby, I had the pleasure of debating him in Cape Town. He's professor of cardiology at Harvard. And here he has an article called The Forgotten Majority. And who's the forgotten majority? The forgotten majority is people who are taking statins who still have heart attacks, which shouldn't happen if the statins are removing the cause, which is the elevated blood cholesterol concentration. And he says very similar to what Professor Tabas said. Despite meaningful progress in the identification of risk factors, deaths from cardiovascular disease continue to increase worldwide. Although pharmacological treatments with statins have reduced cholesterol levels and lowered mortality rates, that is false. They haven't lowered mortality rates. Several large controlled clinical trials have indicated that cardiovascular events continue to occur in, wait for it, 2/3 of all patients. I don't think he means 2/3 of all patients. What he means is 2/3 of all patients who have a heart attack are still taking statins. And that's an important distinction. Although lifestyle modification benefits general health, most people continue to resist changes in their daily routines. So in other words, the patient's at fault. Can't be the hypothesis is wrong. Cholesterol we know causes heart disease, and therefore if we can't get benefit from statins, it's because the patients are not listening to all the good advice we're giving them. So here's a figure from his article And he's looked at 6 major clinical trials of statins. And you'll notice that they've included lots of patients. This study had 20,000 patients. And he's going to see what were the major coronary events in the patients who were on the statins. Now, if statins reverse and prevent coronary heart disease because cholesterol is the cause, then the mortality, the incidence of heart attacks in people who are on these trials taking statins should be 0, as indicated here. It should be right there, 0. So let's see what it is. Oops. There are all the clinical trials, and showing therefore that this is an important point, that 75% of the heart attacks occur in people who are taking statins in these trials. So therefore they are not reversing the condition, and therefore a lower cholesterol or cholesterol itself cannot be the cause of coronary atherosclerosis and coronary artery obstruction and heart attack. So conclusion, an elevated blood cholesterol concentration is not the causa vera of clinically apparent coronary heart disease. And he concludes, we've had that one. So actually, Professor Libby, you're wrong. If drugs at lower blood cholesterol concentrations to the normal range do not prevent further coronary events in those with initially elevated blood cholesterol concentrations, then cholesterol is not the causa vera of the coronary events. Your hypothesis is wrong, and it's time to think about another hypothesis. So here's an article by Foss, Rose, and Byron in 2013, and the great statement somewhere there is the lack of circulating statins is not the cause of atherosclerosis. That's a very good point. So if you were to replace the cause, which is the lack of statins, you replace it with statins, your disease has to go away. He makes the point that in these studies, the 2005 CTT analysis, one would have to treat approximately 1,900 patients with statins for approximately 1 year to extend the life of one person. Statistical significance loses all meaning in this context because the finding is obviously not clinically relevant, as the benefit is extremely small and is not applicable to women. So there are some of the opinions that statins are not reversing coronary artery disease, therefore what they're acting on, which is to lower the blood cholesterol concentration, cannot be the cause. It may be a reason, may be one of many reasons for coronary atherosclerosis, but it's not the cause. So my conclusion is, if significant lowering of blood LDL cholesterol concentrations does not prevent the disease, then LDL cholesterol is not the causa vera of coronary heart disease. Accordingly, the blood cholesterol concentration is one of the reasons for coronary atherosclerosis. It is not the single real cause, the causa vera. Since no one other than Dr. Fred Kumerow, who we discuss later in this series, has an alternative explanation, I conclude that the cause of coronary atherosclerosis is and remains unknown.